Good afternoon. Good afternoon, good morning. I don't know where you are, but we are here with Professor. We are very pleased to welcome Professor Margaret Herridge from Toronto. This is a unique moment, half an hour, for asking many questions on patients, family members in the ICU and after the ICU. Margaret, bonjour.
Bonjour, Élie.
It's a real great pleasure, and we have a lot of things. We could spend 2 days to talk together on what you do on a daily basis at the bedside and on your research. I'm just reminding to the delegates that if there are any questions, you can go to the ESICM website and go on the web TV and ask any question in the chat, and we will address the questions. So Margaret, we have learned a lot from your works and work from other colleagues all over the world on what we should do when we deliver ICU care to a patient thinking on long-term outcomes. And in addition of that, we have learned a lot on qualitative research in emotional things and psychological symptoms, but you provided us with works on qualitative things on physical symptoms. So can you maybe just tell us how this came to your mind to develop this research program and to provide us with all the things that you have done for the patients and the family members?
Well, first, Élie, thanks to you and the ESICM for the kind invitation this morning, and greetings from Toronto. I have to say that maybe my decision to do outcomes work came from a place after training where I wasn't really sure if I've made the right choice about my specialty, because I had so much uncertainty about what happened to patients after we'd invested so much in the ICU. And of course, working in the ICU, there is so much mortality. And I was really concerned about who patients were after they left the ICU. So I think it was from a personal place to really want to understand that in more detail. And that was in the mid-90s. And I think there was certainly a burgeoning literature beginning in this area at that time, which has continued over the last several decades, as we've discussed many times, and with many colleagues engaged in this work. But I think that once we started looking at ARDS patients, and we deliberately chose the ARDS patients because there was a pre-existing literature, but we selected for the most severely ill ARDS patients. And again, deliberately understanding that we wanted to know what those outcomes looked like. And I don't think the intent of the program was to really characterize a lot of multimorbidities and physical issues and, emotional and cognitive issues. That wasn't how it began. I really began the study thinking it would be about pulmonary function and sort of a pulmonary focus. But as we spent more and more time in clinic and spent a long time talking to people, listening to people, examining them, all of these other issues became very evident, and many other investigators around the world have found very similar things. And just as we were doing this work, literature was emerging from Mona Hopkins' group about the cognitive issues. Gustav Schelling in the late 90s was the first to describe PTSD. More and more emerging literature on mood disorders, cognitive issues, and the varied multimorbidities that all of us who do this work now see very commonly, and understanding an ever-expanding inventory of the sequelae of being really sick in the ICU, and naturally putting associations together with some of the ways we deliver care, those that are modifiable and those that may be non-modifiable.
I believe it's very important for the youngest of the people who are listening to us, either know or maybe later in replay, that people with your stature are paying attention to these very basic elements, because when we look at the literature, we see that outcomes from different trials are either that the patients are alive or dead. And you provide us with much more perspective on the long-term outcomes. And I think that the young generation need to have this in mind to be really certain that if this is their intention to work on that, there is a field of research on outcomes that is much beyond being alive or dead, but it is much more qualitative. Mark, what would you say about these trials that have maybe missed the target by only focusing on mortality?
Well, I mean, Élie, I think that if we're talking about, recent trials, for example, in COVID, where there was a huge time sensitivity, I think it's very understandable that people are really going to target mortality as an initial outcome, because obviously that's extremely important. But I think as we, but what I would say is it doesn't preclude studying morbidity, because you can really design that as part of the study elements. You get to those major metrics of mortality, but then understand maybe in follow-up or detailed questionnaires or telephone interviews or Zoom. Now there's such a new opportunity with virtual follow-up that you can really design the study to fill in all those rich details of what the varied outcome signal might be from a given intervention, or how that intervention interacts with the care that we deliver in ICU, and generate new hypotheses from that. And similarly, you alluded to mixed methodology, building in opportunities to interview patients, to interview families, to again add that extra granular detail to the study. So I think that I just wouldn't view them as mutually exclusive. I think they're all complementary elements of a very rich research program, even if the initial metric or the initial outcome is in mortality. All of these other studies are doable. It's just the thoughtful design that goes into them, and understanding that the mortality outcomes in isolation, or even just an exercise outcome in isolation, without understanding all of the domains of morbidity and how those domains interact in any given patient, and understanding also how those domains of illness interact with the family and affect the family. And there's sort of a bidirectional influence between family and caregiver, and that the basic metric really probably needs to be the dyad, or the patient-family interaction.
Thank you very much, Margaret. Mark, with the COVID-19 pandemic, we have been flooded not only by the numbers, but also by reorganization, by having many patients everywhere, including critically ill patients outside the ICU departments.
Yeah.
What can we expect? So we know that there is an ongoing research on the follow-up of COVID-19 survivors. What can we expect from this research? So do you have any data from your own research? And is there something that we can draw from the experience of the previous pandemics, like MERS, like SARS, and other things that happened in the last 3 decades?
Mm-hmm. Well, maybe I'll start with the MERS and SARS parallel, Élie. I think sometimes for all of us, we don't spend enough time looking back and actually being good students of historic literature, and just replicating things for which there are already answers or very helpful directions to take. The SARS epidemic or outbreak in Toronto, and MERS, I think it really taught us that we will see disability, we will see a very important mental health signal, we will see stigma, We may see cognitive issues as well. So many of the domains that we already see in the emerging COVID-19 literature are already in the literature in SARS, so SARS-CoV-1, and in MERS, perhaps to a lesser extent, but the themes are robust. I think the emerging literature in COVID-19 is extremely instructive in terms of health policy issues, health utilization issues, and in the general prolonged mechanical ventilation and chronic critical illness literature and ARDS and SARS. You put them all together and you see very robust overlapping themes of patients who spend a long time in the ICU. They come in with severe lung injury, and then they develop a host of problems related to being prolonged mechanical ventilation patients. And they acquire the chronicity complications and the iatrogenic complications that really transform them. And after a few weeks, place them into very different trajectories. And a very nice paper by Mark Unrow and Chris Cox, and it's a gorgeous figure. It shows how Byzantine the care transitions are after critical illness in these prolonged mechanically ventilated patients. And I think as we think about COVID-19, it's clear that around the world, COVID-19 has exposed a lot of health inequity, exposed a lot of differential care for vulnerable patient populations. We really need to be cognizant of challenging care transitions and really healthcare systems that are probably ill-equipped or ill-prepared at the very least to deal with the tsunami of all of the disability that is really heading our way. But again, lots of lessons to learn from in these previous areas of literature: ARDS, SARS, MERS, sepsis, chronic critical illness, the COVID-19 literature. Bin Cao's group in Wuhan has published the one-year data in Lancet, many similar, and there are all sorts of other cohorts that will publish their one-year data coming up. And the themes are very robust. Here in Canada, in our CANCOV study that I'm leading with my colleague Angela Chung, very similar themes. A lot of stigma, problems with resilience, mental health, cognitive issues, functional disability, chronic lung disease, actually. I think lots to learn, but from older literature, and lots to learn now from new things that we discover from COVID-19.
Thank you, Margaret. Mark, can we make a step back and provide the perspective for again, the young generation? Mm-hmm. We are specialized in our university hospitals, in ECMO centers, in immunocompromised patients, in patients with prolonged mechanical ventilation. But overall, if we are taking the definition, the RDS definition, by having a low PF ratio below 300, and we look at the entire population, we still have very good outcomes. And overall, survival is very high. And all the efforts that doctors, nurses, and all elite professionals, all these things that are made are very useful. But now we often focus on a group of patients. What do you think is the representation of this group as compared to the entire group of RDS patients? Is this 10%? Is this 25%?
Sorry, Ellie, I'm not quite sure I understand. You mean in...
When we are reporting on outcomes after RDS in multiple center study, we often involve centers on very specialized ICUs that don't have maybe a representative sample of what is RDS overall. But mortality in RDS overall, if we are looking at trials or at big cohorts, is certainly around 20 to 30%. So we have 70% survival.
Yeah, for sure.
Yeah, so all the efforts that are made are very useful. So what would you say, should we provide follow-up for everyone after the ICU? Or should we maybe stratify on things that happen in the ICU, like the number of days of mechanical ventilation?
Yeah. So thanks for that, Ellie. Yeah, I think that it's clear that, yeah, and maybe I can just also restate what you're saying, that critical care has provided enormous developments and innovations in the last several decades. And we're absolutely saving people who historically would have died. There's no question about that. And I think, when you tend to focus on morbidity in a research career, I would want to also be very quick to state the enormous innovations that we've made. And that's really why we're able to study morbidity, is because people are surviving. And I think maybe the big chapter too here is understanding that we save so many people, really turning our lens now to how we can minimize or mitigate disability. And that's an exciting prospect in terms of really fine-tuning how to improve these outcomes in the longer term. To more specifically answer your question, there's no question that there are a lot of risk groups who have clear vulnerabilities, and these are our older patients. This isn't ageism. There's a robust literature, and it makes sense because senescence is the loss of biological reserve. That's normal aging. Our patients who come to us with a lot of multimorbidities, this is also a clear group to target. Patients who are on a declining health trajectory, these are also patients to target. And, some early work on trajectories from Jack Kawashina illustrates this. Amber Barnato, Professor Guidé, many others looking in older patient populations clearly show these signals that there is enhanced vulnerability in their trajectories. In our own Recover group, we looked at patients who are mechanically ventilated for a week or longer. Terry Huff in the US is looking at a similar cohort of patients. And this arose from the chronically critically ill patient studies from Shannon Carson and others. It's clear that after a week, and probably even after 3 or 4 days, you have a sense in an ICU of who's going to stay for a long time with you and who's going to have challenges related to ICU acquired weakness, or related to comorbid burden, or related to age, or pre-existing trajectories or other health issues. So I think increasingly how long you spend and some of these risk factors that I've mentioned in the ICU will enable us to target a smaller proportion of patients and their families who really would benefit from a more structured follow-up.
Thank you very much, Mark. Mark, one thing that strikes me a lot when I look at the literature on emotional burden after critical care illness, I'm very surprised to see that family members who did not per se undergo mechanical ventilation and all the physical things in the ICU are still themselves with what is called the PICS, the post-ICU, the post-intensive care syndrome. And can you tell us more about how these family members, who are sometimes in patients after RDS, sicker than the patient themselves? And what are the data? And should we also take care of them in addition to our patients?
Well, Ellie, I think you're the expert on the caregiver question, not me, actually. Yeah, I mean, I think, and just let me also, acknowledge Dr. Needham and Davidson's work in terms of PICS and PICS family, and how their construct, brought together a lot of earlier constructs from the post-ARDS sepsis and chronic critical illness literature. I think it's true. The families, well, as you know, and Nancy and so many others who you've worked with, Professor Pochard, many others. I mean, they have their own traumatic experience in the ICU. And it does look different, but it's very damaging and can be quite durable. I think it's still, we're still learning how, what the risk groups are for the caregivers in terms of how severely ill they become. There's no question that patients, family caregivers with pre-existing mental health problems have vulnerability. There's an emerging literature on caregiver suicide, and this is an important risk factor for that. But I think I would equally say and defer to you, Ellie, that you do not need to have pre-existing mental health problems as a family caregiver to develop pretty serious mental health issues after critical illness. And we're certainly seeing that theme. We've certainly seen that theme in the historic literature led by you and many others. And that theme is very robust in the COVID-19 patients, COVID-19 family caregivers as well. So again, echoing the COVID-19 outcomes literature in ICU patients, anyway, echoing the historic literature that is very robust at this point.
There's an interesting question on the chat on, so how can we select those family members and with whom we need to develop special communication programs to help them and to assist them? So you very nicely reported that 7 days of mechanical ventilation seems to be the threshold of time making the difference. So should we inform those family members of patients with prolonged mechanical ventilation or on ECMO on the different things to expect, just to make them from the very beginning understand how we behave, how we make our decisions with them, how we can collaborate and maybe navigate in the ICU for the days and weeks that are going to come?
Yeah, well, I would say that when I first started doing outcomes work and I talked to patients in the clinic and their families because they came together, I would try to give people a lot of information. And over the years, I had so much feedback from the patients and the families that they said to me it would be more helpful to ask people how much information they wanted to receive, because they were then signaling that they were ready to maybe receive information that could be difficult or disturbing. I would just share that with our CANCOV study here in Canada, we have never had so few caregivers agree to be in the studies. The caregivers are so traumatized, and we've been recruiting from very sick case mixes here for COVID-19, a lot of ECLS patients, but we've never had so many caregivers decline. And the reasons that most of them have declined, some of them are sick, so that's one important reason, themselves with COVID. But the other issue is that they said they were absolutely and utterly overwhelmed. And I don't think that, and they were being physically separated through most of these waves from their loved one. I think that, so I think it may be helpful to give information, but I think we have to be cautious about overburdening with disturbing information that may or may not be the reality for that particular person. I think it presents a possibility that it can further overwhelm people. I think understanding that the patients and the families are at high risk when they spend more time with us, although not exclusively, and being aware of it, ensuring the communication is excellent, is truthful, and to be honest about uncertainty. This is another thing I heard so much in the clinic, that the patients and the families want to hear uncertainty when it's the truth and don't want to receive sort of, pat or stereotypic answers, or they know genuine communication when they hear it, and they understand complexity, and they understand uncertainty, and want to hear that. So I think it's important to have a high suspicion that people may need mental health resources, and the longer they stay, the greater the likelihood of that, I think. But I would also just want a message to the audience that I got that feedback from the patients and families to be very careful about overburdening people with too much information that may not necessarily affect them, but that in the moment might add another increment of stress.
Thank you very much, Margaret. We still have a few minutes, and I would like to spend a little bit of time on the Recover program. I think that one of the things that would be very different in the Recover as compared to other programs that are also wonderful is the importance of the interprofessional team and the way where everyone has a role, not only in caring, but also in research by working with translational research, by physiotherapy, by respiratory therapy. So everyone has a role. So we are a chain. Can you tell us more about how you did build this team and how this translated into the importance of your works in your Recover and in other works that you performed on outcomes?
Thanks, Ellie. I guess I would say that so many people are doing work in this area. So we started doing work with our Recover program in about 2006 or so, kind of on the heels of our ARDS and SARS work, and based a lot on the learnings from that. But there's so many networks and people who are doing this work now. I could name 10 people, I mean, there's so many important networks now, the Thrive Network, there are important networks in the UK. Tim Walsh's group has done their own UK Recover program. Inspire is an important program. I mean, there are many international programs in Australia as well. Carol Hodgson, her PT colleagues there, Linda Dennehy, super, lots of people are doing this important work here in Canada, Michelle Coe too. So I just want to say that, I mean, we're now one of many, many groups, which is actually really fantastic. I think that was kind of organic for our group, that I thought the ICU follow-up should follow the same structure as the acute ICU. It just seemed to make sense. And the rehab models for other diseases tend to follow that model. There was nothing really novel or innovative about that particularly. I think what we were trying to do in Recover that may have been slightly different was to take the navigator model from the oncology literature to create someone who really follows the patient and family as to help them literally navigate the care transitions, these difficult care transitions that we've talked about before. I think that was a newer element that we tried to bring in, but again, we were borrowing from other groups who had success with complex patients. And I think that what we were really trying to do was create that continuum of care, that continuum of rehab, but also provide an educational focus so that, all the clinicians, all of the clinicians who are part of the interprofessional team could learn from the patient and the caregiver through the care transitions and in follow-up clinic, and the trainees too. And because when you do follow-up, it transforms your clinical practice in the ICU. You see things differently. You see them through the lens of hopefully modifiable disabilities or modifiable mood disorders or cognitive issues or pressure injuries or all of these sorts of things. And I think it really is important that our trainees understand the continuum of care and the continuum of rehabilitation and are able to learn how difficult these care transitions are for patients, for families, how they really have nowhere to turn. Often the clinic and other programs, and I know other colleagues who do this work find the same, you become the place that the families and the patients return to for advocacy, for access to care, because the system may not naturally work so efficiently for them. Their primary care physician may not truly understand the constellation of multimorbidities. And, your perspective, your lens is quite different. And you can really be a very, very effective patient and family advocate. I would say here in Toronto, in Canada, I think probably like lots of parts of the world, it's hard to access mental health resources. And so this is actually our number one referral is to mental health.
Thank you very much, Margaret. I think that we have spent these 30 minutes together, and I'm sure that most of people who are looking at us hope for much more, and ESICM is providing much more in weekly and sometimes daily webinars. You can see that again in replay, and we will have many opportunities in the close future and face-to-face meetings also in 2022. And Margaret, we really spent a good time talking to you, learning from your research and from your perspective. And if you want to say goodbye to everyone, so I'm giving you the podium for the last seconds. Thank you.
Thanks, Élie. Thanks for the opportunity to chat today. Thanks to ESICM for the kind opportunity to speak today.
Thank you and goodbye. Have a good day.
Okay, bye-bye.